Hello everyone. We welcome you all to another lecture on this expert lecture series, which is supported by conscious sedation concept. And the title of this series is Oral Health Talks. So today's lecture will be presented by myself, Dr. Mohammed Ziauddeen. I am working as assistant professor at the College of Dentistry in Majmaah University. I belong to the Department of Prosthodontics. So, naturally, I will be speaking about a topic related to my specialty, that is overdentures today. And this lecture is intended to the audience group who belong to undergraduates category, and also in general who would like to know about what this overdenture is all about as a treatment option in prosthodontics. So in this lecture, specifically will cover certain learning objectives, that is the indications and contraindications of overdentures, what are the advantages and disadvantages, and types of overdentures, and attachments that are used in overdentures, and a little bit about implants as well in overdenture treatment. So we'll be covering them under these topics, including definition, the rationale, indications, contraindications, advantages, disadvantages, and then the classification followed by procedure, and then a little bit about implant supported overdenture. By definition, an overdenture, it is defined as a removable partial or complete denture that covers or rests on one or more remaining natural teeth or the roots of the teeth or on dental implants. As you see in this image, the top image, you can see certain the lower mandibular arch is shown here, and then you have two retained canine roots on top of which we fabricate a denture. The denture is called overdenture, and the lower image shows a few implants and then some attachments on the implant. So naturally, a denture constructed on top of that would be implant supported overdenture. So this is by definition. So there are some certain other synonyms for this denture. So we call them overlay denture, hybrid prosthesis, telescopic denture, biologic denture, superimposed prosthesis, tooth supported denture, and complete overdenture or partial overdenture. So all these are synonyms for overdentures. So before we go into the very details of indications and contraindications and the advantages and disadvantages, let us first understand why do we need this overdenture? What is the rationale for using this concept? For this, I think most of the undergrad students in dentistry, they are aware of a concept called preventive orthodontics, right? So in preventive ortho, what the doctor plans or intents is before a malocclusion sets in, the doctor would want to prevent it by certain measures, right? So here we get introduced to a new terminology called preventive prosthodontics. So you might be wondering, before losing teeth, something can be done. No, this is not the direction of thought. But a more specific is what happens once after the tooth is lost. What happens is there is an accompanying bone resorption, right? So this preventive prosthodontic concept aims to prevent that bone resorption. Okay, so which is usually secondary to wearing prosthesis. What happens? It is accompanied by bone resorption, right? So this concept aims to prevent it. So that's why it is otherwise known as preventive prosthodontics. So what do we use for this preventive prosthodontics? We use the roots of the tooth. And as you saw in definition, we also use the implants, right, to hold the bone together so that doesn't get resorbed quickly. And certain other rationale is by maintaining the teeth, we also maintain the integrity of the residual ridge, and also it tends to give, or maintain the sensory and kinesthetic perception, which is lost. As we all know that the receptors lie within the periodontal ligament of the tooth, So what happens once extraction is done, all this perception is lost, right? So to preserve that, this overdenture concept helps the patient indirectly. And it also maintains the sensory input from the PDL. So this is also an advantage. And there is another name for you know intentionally preserving the root. So it's called submucosal vital root retention, wherein and the most preferred segment is in the anterior region. Uh, where we usually prefer the canines, and the second preference would be the second premolar, where we preserve and construct a denture on top of that. So this concept is otherwise known as submucosal vital root retention. And what happens is, by preserving these teeth along with the integrity of bone, the alveolar bone is preserved. And there's a old research conducted by Ricin et al. As early as 1971, and he found out that it increases the masticatory performance also. As you see here, the chewing efficiency is raised by 1/3 time higher than the conventional dentures. So it's a kind of a win-win situation wherein bone is also preserved as well as the masticatory efficiency is also increased for those patients. So, what are the indications? Indications would be patients with badly worn teeth, patients with few remaining natural teeth, and usual scenario in a complete denture where we, at the end of case history, we categorize the case to be having poor prognosis, like patients who have low palatal vault, or patients with poor sublingual space, or patients with class 3 tongue or knife edge ridge. So all these cases we categorize them as poor prognosis, right, with our routine complete denture. So especially if you follow this overdenture concept in these cases, it is going to help the prognosis. And you have certain congenital or acquired intraoral defects such as cleft lip, or palate patients with few remaining teeth. So we can apply this concept. And abnormalities in jaw size and position. So what happens to aid in retention, or to achieve better stability, we can use this overdenture concept. And mandibular arch, where loss of alveolar bone is more rapid because of the surface area of the arch in comparison to maxilla. So what happens is the mandibular arch tends to resolve faster. So to prevent that, we can apply this concept here. And then we have edentulous maxilla opposed by natural dentition. This is called combination syndrome. In combination syndrome, what happens is, when it usually occurs in edentulous maxilla, um, and the opposing arch has a class 1 Kennedy's arch. Like, there are natural teeth only in the anterior segment, and the posterior segment is edentulous, right? So in those conditions, we expect the patient to go into in developing a combination syndrome. So to avoid that, we can adopt this overdenture concept in the mandibular arch. And post-traumatic or post-surgical cases wherein a few teeth are preserved. So here as well, we can go for overdentures. And then in patients with severe attrition, loss of vertical dimension, when certain teeth with poor prognosis are removed or extracted, with the remaining teeth, we can go for overdentures. Younger the patient, greater is the indication, because younger patient tend to have a better periodontal support. So the teeth that you are maintaining tends to serve for a longer duration. So younger patients who require overdenture, they can be a better candidates for this overdenture treatment. And also patients with cleft palate, as I told you before, who have a large freeway space. Especially when you have large freeway space, what happens is um, there can be a loss of stability or instability in the denture. This overdenture concept will help you improve in that. And attachment supported, we'll see in subsequent slides what are these attachments. So they may be indicated in cases of xerostomia cases where you want to improve the retention for the dentures. Overdenture, actually, it is a simple approach, where we follow in patients, especially who are already, on the deficient side with the tooth structure. So, like for example, you see this microdontia or partial anodontia. So all these cases, they are, you know, there is an inherent deficiency in the tooth structure. So rather than, even to um, to make it worsen, so what we can do is we can do a preventive concept. That is, we can maintain these teeth and maybe we can reshape this tooth structure and fabricate a denture on top of it to improve the situation. What are the criteria that we have to follow? Can we just go ahead and, and choose any case to for overdenture treatment? No, there is certain criteria proposed here. So the first criteria is one tooth per quadrant. That is the first criteria that is usually recommended. And the next criteria is not adjacent teeth to be used as overdenture. Like I will show you an image here. Here you can see here. Usually this kind of a scenario is not preferred. A gap of at least one tooth should be given if you want to go for more than one tooth in a quadrant. So this is the second criteria that we follow. And the third criteria is usual preferences. Usually mandibular cuspids and premolar are preferred as overdenture abutments. Then next preference, or sometimes not much preferred candidates, would be maxillary cuspid. Because what happens is this maxillary cuspid, if we take them as overdenture abutments and we fabricate a denture, there there usually results in soft tissue undercut on the buccal aspect or the labial aspect of the abutment, and this results in a poor aesthetics and also poor retention. I will show you in subsequent slide. And then overdenture is regarded as a transitional process, but definitely the success of the processes lies on the maintenance of very good oral hygiene for the by the patient. And as you see here, um, there are certain criteria in selecting the patients as well. Age would be the first criteria. Younger the patient, the better it is, as I told you before, because of the periodontal support that the apartments can offer with a younger individual. And the state of a general health of the patient also has a say, and a history of previous dental treatment and attitude towards dental treatment. All these point towards one thing, that is the cooperation of the patient towards maintaining this abutments for overdenture treatment. So then the next question, when so much emphasis is on the apartment selection, how do we do the apartment selection? So the first thing, the primary criteria is to go for a proper crown is to root ratio. Next is how good the apartment can offer retention and support. And the third criteria would be whether you want to go for a single or multiple. Okay. And as we earlier saw, a single tooth per quadrant would be the preferred option. But in some cases, some physicians, they also prefer multiple. So let's see all those options as well. So the factors that contribute towards the selection of the abutments would be, the first primary thing would be the periodontal status. If the tooth is going to have a bad periodontium, it's better to go for extraction and go for your routine complete denture removal prosthesis. So the first primary criteria would be the periodontal status. Next would be the number and location within the arch. And next would be the integrity of tooth structure. How good can it offer support for the overdentures? And suitability for endodontic procedures would be the next criteria after perio. Like if endo cannot be done for those abutments, there is no point. Or if there is an infection that says that any relapse can happen, it's gonna go for failure. It's better to extract those teeth and go for a routine prosthesis. And presence of associated bony undercuts, as we see for mouth preparation for any prosthesis, right? For removable prosthesis. So this is associated with the mouth preparation. So any bony undercuts, we usually try to avoid overdentures. We try to reduce the undercut and go for a prosthesis. Then ability to offer positive retention is also a criteria that we have to select. We have to think of while selecting the apartment. And last but not the least, the economics, because of the cost involved in the procedure. So ideal teeth that would be preferred would be the canines, and especially the mandibular canines. Next best preferred tooth would be the second premolars, the naturally the mandibular second premolars, and the order of preference next points towards molars, which is not very much preferred, because what happens is when you prefer posterior abutments, there is very less interact space. So you would end up having very less space. So arrangement of teeth becomes difficult. And even if you trim and arrange in that area, what happens is later on it can go for the prosthesis becomes very thin in those areas and it can go for fracture. And the least preferred would be the central incisors, which is not a very good option because, again, teeth arrangement in that area is going to be a problem, which you cannot achieve very good aesthetics if you select central incisors as your overdenture abutment. So, any um, problems that are associated with the abutments or the prognosis of the abutments would certainly drive us towards not going for the process. So naturally the contraindications would include patients with high Clary's index or poor oral hygiene, poor prognosis for the abutment. So all these things would be primary contraindication for these overdenture treatment. Next would be reduced interact space. Already the space is compromised, so you don't want to add up to the trouble by taking the overdenture abutments, and then you will have a nightmare in arranging the teeth. And then huge undercuts, again, as we discussed earlier, which is to do something with the mouth preparation. And when there is huge undercut, naturally we do not prefer huge undercuts for your removable prosthesis, because of the sheer insertion and removal becomes a nightmare for the patient. So again, it's a contraindication. Insufficient attached gingiva also contraindication here because of the abutments. And then where endo and perio treatment cannot be performed, better to go for extraction in those cases. And as we discussed before, preservation of alveolar bone would be the primary advantage. Other advantages would be maintenance of proprioception and increased masticatory efficiency and increased support and stability. All that would be your additional advantages that you get with your overdenture treatment. And then last but not the least, I would like to drive your attention towards convertibility. So these overdenture, prosthesis, when you have fabricated, later on, if for some reason the abutment goes for extraction or the implant fails, it can definitely be converted to your routine removable prosthesis, complete denture prosthesis. What are the disadvantages? Again, everything drives towards your abutment. Carry susceptibility can be a disadvantage. What happens is around the abutments, oral hygiene maintenance sometimes become difficult, or if the patient is not cooperative, it goes for extraction. So that is a disadvantage. Encroachment into interocclusal distance, as discussed earlier. Aesthetics, this is what I was telling that I would discuss on subsequent slide. As you can see here, this is your first and your second quadrant. Can On the image, you can see here the canines have been used as overdenture abutment, and you can see your huge undercut above the canines. So what happens is if you fabricate your denture on top of that, you might have to trim so much of your denture flange for using this prosthesis. So for the patient to insert and remove this prosthesis. So what happens is if the patient has a high smile and definitely aesthetics becomes a very big concern for this patient, and then that area also becomes weak and later on can go in for fracture. So these are all certain disadvantages. Other disadvantage would be periodontal breakdown of abutment teeth, and also there is high initial cost involved, and breakage of denture is very common, these overdentures, because of stress concentration in these abutment teeth, and very meticulous maintenance of oral hygiene is needed for these patients for the success of these processes. So let's move on to the classification. As we see here, overdentures, they are classified into tooth-supported and implant-supported overdentures. Broadly, they are classified into tooth-supported and implant-supported ones. And the tooth-supported are subsequently, they are classified into non-coping ones and you have coping ones. We'll see what are these copings and non-copings. And then you have attachments. Attachments can be subsequently divided into studs or bars or magnets. So all these things, these attachments, they improve retention for the that can be offered for the prosthesis. So you see here, non-coping ones, non-coping type of overdenture can be, these abutments can just be reshaped into a conical structure, the remaining tooth structure as you see in the image, and can be used as an abutment. They can be done either ways, in either like you can do an endodontic treatment, or in certain patients where you feel there is a good amount of reparative dentin and the patient doesn't feel a lot of sensitivity, then you can, without endo also, you can just make it into a conical structure and use it as an overdenture abutment. So, but commonly we go for copings, and as you see here, it is a kind of a thin metallic structure that is cemented on top of this overdenture abutments. So, when are these indicated? These are indicated when there is previous caries lesion. Already, the structure is weak, and especially if this lesion or restoration is extending below the level of gingival margin. So you want to make the structure a little stronger. So what you do is you make this coping and you cement it, and then go in for your denture on top of it. So when you have decided that there is, and see, there is also another indication. It's also indicated when natural teeth is present in the opposing arch. So you want to, when you anticipate a lot of forces that is going to fall on this abutment, so you can go in for your copings for this abutment. There are different types of copings. Certain copings are called long copings when they are around 6 to 8 millimeters, and certain copings are categorized into medium copings, which are around 4 to 6 millimeters, and there are certain other type of copings called cast copings. Cast post copings, which are tall, and there are also cast post copings which are short. So we see this long and medium copings. As you see here, the longer copings, they are called as, they they look like telescopes, right? When you attach these long copings on the tooth and you fabricate a denture on top of that, as you see in the image. So this kind of remains as something called telescopes. So this type of denture can be planted in patients who have large intract space. And as you see, with the height, you get better retention and stability. So this is the advantage of using long copings. And then you have, when certain patients with lesser intract space, you can go for medium copings. Again, these two can offer you a decent amount of retention and stability. So when there is not much of a tooth structure coronally, so what you can do is you can take some support from the root by making a post and core, and getting it casted. And again, this can be a tall one or a short one, as you see in the image. And when you do this cast post, you cement it on top of the tooth. Naturally, a post base preparation has to be done, and an impression has to be made, and a cast post along with a coping kind of prosthesis is fabricated in the lab and then cemented in the patient's mouth. You have these two images. You see one on your left side is a shorter one, at the right side is a taller one. You cement it in the patient's mouth, then you can proceed with your overdenture, your denture on top. So you have certain types of attachments that can also be used on top of these abutments. So we broadly classify these attachments to be extraradicular or intraradicular. As you see here, as the name suggests, extraradicular is something that lies on top of the root of the tooth, and intraradicular is something that goes within the root. So you have these two categories, and other than that, you have two more categories that are classified as rigid and resilient attachments. You see on the topmost image shows you a spring within the attachment that offers you some amount of movement. So you get some flexibility. So the major advantage of using this resilient attachment is that because of this flexible nature of your attachment, less force gets transmitted onto your overdenture abutments. So going on to the procedure, first and foremost would be selection of the abutment teeth, a criteria that we have discussed before itself. So once you've selected the abutment teeth, then you decide on what type of what type of coping you want to go, whether you want to go for a coping or non-coping ones, or like any attachment you're planning for that. You first decide on that. Then before that, you go for your preparatory treatment. That is any perio or endo treatment that has to be done for this process is done, and then your coping planned, fabricated, and cemented on the tooth. Then we go for final impression with a custom tray fabricated. Final impression material can be anything. A preferable one would be your rubber based one, and of course you have to do a bottom molding, and then your final impression. Then once you've done your final impression, you fabricate a master cast, on top of which you fabricate the occlusal trim. A jaw relation is done in a routine way, and then a try in is done after teeth arrangement as shown in this image, and then you proceed with your equalization. So these are the step that we follow for your overdenture. Now, a little bit briefly, let us discuss on the implant-supported type of overdenture. So, this is especially indicated in patients who desire for implant. Nowadays, we live in the age of dental implants, where the dentist does not necessarily feed a lot of information. The patient themselves have, request for implant treatment nowadays. So with desire, this can be a preferred option. And when the systemic status or the health of the patient is good, and the bone quantity is good, and the patient can also maintain the implants properly, and we can go for the implant supported overdentures. And a most preferred option in maxilla would be, because the maxillary bone is categorized to be a D4 bone, D4 according to our vicious classification. So what happens is, because of the spongy nature of maxillary bone, at least four implants are preferred in maxilla, on top of which you can fabricate a overdenture. And the overdenture can be, and it's also preferred that you splint those implants for maxilla and then fabricate a denture on top. Mandibular, because of the cortical nature of the mandibular bone, two implants minimum would suffice, and you can sometimes prefer four also. And the preferred site of implant placement would be the canine region and intercanine region. And then a denture can be fabricated on top. So this is a little bit of an insight into your implant supported overdentures. And contraindications for such treatment would be, any first thing would be any contraindication for surgery for the patient. That if the general health doesn't allow for surgical intervention, you don't go in for the implant therapy. And then when there is in the residual since the implant has to be placed on a good amount of alveolar bone, when there is extensive surgery that is required for cases, then usually it is not preferred. And any contraindication for general surgical procedure holds good for implant therapy here as well. So this is a broad view about your overdenture treatment for prosthetics. So I would suggest more in-depth reading for the listeners, for the viewers, to go into a better exhaustive lectures, or to have a better reading with literature, to have still more information about overdentures. And thank you so much for your patient listening. Again, on behalf of the Oral Health Talks team, we thank you, and also extend our thanks to our sponsor, that is Conscious Sedation Consent. Thank you so much for your patient listening. Thank you so much. And also, I would like to say that Oral Health Talks has a series of lectures covering a wide range of topics, dental topics, with the target audience being undergraduate dental students. So, I would request to like, subscribe, and share our videos. And any doubts or any topics that you would like to cover, please send us or mail us at oralhealthtalksindia@gmail.com. We would be glad to address those issues. Thank you. Thank you so much.